Hello, everyone. Welcome to the MGFA Wellness Series. This webinar will be on lifestyle and MG. I would like to go ahead and thank our sponsors, Alexion, Argenix, UCB, and also Horizon, Janssen, and Caballetto Bio. Our first speaker, Dr. Goyal from Stanford, is going to do the introductions, and I'm going to turn it over to her.
Thank you, Dova. All right. Well, good morning, good afternoon, everyone. Today we'll be continuing our MGFA Wellness series, discussing lifestyle factors in myasthenia gravis. So really for the next 50 minutes or so, you're going to be hearing from us, and our goal is to answer the question, what lifestyle changes can you make to improve your myasthenia? You'll be hearing from myself, Dr. Neelam Goyal. I'm an adult neuromuscular specialist at Stanford with a special interest in myasthenia gravis. You'll be also hearing from Dr. Simone Birnbaum, PT, PhD, research physiotherapist, currently at the Association Institute of Myology in Paris, France. And below are our disclosures. So for the first 25 minutes or so, you're going to be hearing about diet, gut microbiome, marijuana and derivatives, and stress and its role in myasthenia gravis. Then Dr. Birnbaum will be talking about exercise in myasthenia gravis. And then for the last 10 to 15 minutes or so, we'll open it up to questions and answers. So I'll be speaking to you about diet, gut microbiome, stress, and marijuana and derivatives. I want to start the talk by saying that unfortunately, I don't have a lot of high-level randomized placebo-controlled data to review. But that being said, these topics are really important and commonly asked questions from my patients with MG. So it is important to look at the data, look at what's available in the literature, and at least think about what are some best practices when thinking about these topics. So let's go ahead and talk about diet. So when patients ask me about diet, common questions include, does what I eat impact my MG? And can I change my diet to reduce future relapse of MG? So Dova, I'll have you launch the first Zoom question. So we'll give you about 30 seconds or so to answer this question. True or false? I have changed my diet in hopes of getting my MG under better control. All right, so looking at the results, it looks like about a third of you have tried to change your diet in hopes of getting your MG under better control. All right, so what does the literature tell us? So when you look into diet and myasthenia gravis, you do start to see some case reports of a potential association between celiac disease and myasthenia gravis. So celiac disease is an autoimmune disease where the body attacks gluten in diet, leading to intestine inflammation, abdominal symptoms like pain and bloating, and malabsorption. Although celiac disease is rare, celiac insensitivity is more common. And if you look in the literature, there are many case reports of MG in patients that have diagnosed celiac disease. But interestingly, if you control the celiac disease, you put the patient on a gluten-free diet, the MG did not resolve. Also, last year, there was a nationwide population study in Sweden, which showed no increased risk of MG in patients with celiac disease. So if you have tried to control or reduce gluten intake and see how it impacts your MG, at this point, we can say there may be an association, but no clear data that getting rid of gluten will impact your MG. There was another interesting study where they looked at changes to Myasthenia gravis during the month of Ramadan, which is the religious Muslim holiday for 30 days of fasting. So they had 113 patients, 93 patients had generalized disease, and they were fasting for about 15 hours a day. So what did the results show? So it showed that during this period, the vast majority of patients, 91 patients, were stable, so they had no changes in their myasthenia. 17 got worse and 5 got better. But those that got worse did return back to their MG baseline after the period of fasting. So perhaps this tells us that dramatic changes in diet, including long duration of fasting, largely did not impact MG. And if there was an impact, it resolved once the diet went back to normal. This was an interesting study where they looked at a patient. So it was just a description of one patient. This was a 56-year-old female. She had multiple comorbidities, but also had myasthenia gravis and Lambert-Eaton myasthenic syndrome. So they put this highly motivated patient on a 5-month trial of whole food plant-based diet. And they tried to see if there was any impact on some general measures, quality of life measures, and also myasthenia gravis measure. So her whole food plant-based diet, she was recommended to avoid animal products, minimize highly processed foods, focus on consuming whole foods, and limit extraneous sources of fat, such as vegetable oils commonly used in cooking. She was allowed to eat gluten, but she had previously tested negative for celiac disease, and she herself had already tried a gluten-free diet, which did not impact her disease. And so functionality, biometrics, and quality of life were assessed at the end of the trial. So this was a list of her medications. I just wanted to highlight that she was on 32 medications. 19 were prescription medications. And interestingly, she was also taking probiotics and marijuana derivatives, things that we'll be discussing later in this talk. So what did the results show? So after 5 months of this diet, again, this is just in one patient, she lost about 19 pounds. And perhaps because of that weight loss and her diet changes, she had improvement in her blood glucose and blood pressure, which allowed her to stop 2 of her medications. For the MG outcome, they followed the MG impairment index, and the study reported that she did have improvement in her MGII because she gained 12 points. However, if you look at the index, a gain in points is actually worsening of disease. So I will have to send a message to the author to clarify this result. When thinking about MG and diet, there are other factors to consider. Myasthenia gravis can affect muscles of chewing and swallowing. So if you are currently in a MG flare, what's more important is the consistency of the food that you're eating to prevent things like aspiration and choking. Also, many patients with MG are treated with steroids, and we know steroids can cause weight gain, elevation in sugar levels, blood pressure, bone loss. So you may want to modify your diet to mitigate some of this long-term complications. Also, some of the medications we prescribe can also cause GI side effects like abdominal pain, diarrhea, and this can impact your diet as well. So what's the bottom line with MG and diet? So currently there's really no data on what you can eat or avoid eating that will impact your MG. However, there are best practices. I would say eat a healthy diet. No one can argue against water, fruits, vegetable, protein. And if you have other comorbidities, see if you can speak to a dietitian that can give specific recommendations about what you should be eating based on your other health conditions. Let's now move on to gut microbiome. So recently, I've had a few patients ask me or say to me, I have been hearing about gut microbiome and autoimmune disorders. Is there any information regarding MG? Can I change my gut microbiome to improve my MG? So what does the literature tell us? So gut microbiome is a community of microorganisms protozoa, archaea, eukaryotes, viruses, and bacteria that live in our digestive tract. The largest concentration of the microbiome is in our colon, is made up of bacterial cells, 10 to the power of 13. Now, the thought is that the gut microbiome and their unique metabolites may play a role in host physiological, so human physiological function, including metabolism, and here is where MG plays a role, development and homeostasis of immunity and the nervous system. So the hypothesis is that the changes of the gut microbiome may be associated with the pathogenesis of MG. So here's a summary of some of the current studies that have been done looking into this. So what these studies did is they looked at the fecal microbiome of patients with myasthenia gravis and compared it to healthy control. And here I have a summary of 3 studies that looked into it, and there were some common themes that were seen in a few of these studies. So first was that firmicutes were the dominant fecal microbes, both in healthy controls and in MG subjects. They noted that the level of actinobacteria was lower in healthy controls. It was noted that the level of Bacteroidetes was higher in MG patients. And importantly, the level of Clostridium bacteria were much lower in the MG patients compared to healthy controls. So here's the proposed mechanism. So in the MG gut microbiome, we've noticed a few changes. One of them is reduction of this class of microbes called Clostridia. And the thought is that Clostridia, through breakdown of fats and carbohydrates, creates these short chain fatty acids. And these short chain fatty acids, through 2 different mechanisms, including increase of TGF beta-1 growth factor and dendritic cells, lead to a common pathway of increase of the CD4 positive Treg cells. And the hypothesis is that an increase of these cells in normal humans leads to suppression of the AChR autoantibody and autoreactive B cells. So this is what's happening in the healthy gut. But in MG, because you have reduction of this Clostridia, you have an increase or lack of suppression of the development of these AChR autoantibodies and autoreactive B cells. Interestingly, one of the studies, the first one, Zheng et al., tried to see if there was an association with the gut microbiome and MG parameters. And what they showed was that some microbes, and I have them listed below, were particularly linked with MG severity. And interestingly, they also showed that a combination of microbial markers and their metabolites, so a combination of these parameters, they were able to discriminate between MG and healthy controls by 100% accuracy. There's also literature looking into the oral microbiome. So similarly to the other studies, this was a study published just a few months ago that compared the microbe profile in the oral flora of AChR positive MG patients and healthy control. And they used this RNA gene sequencing method. And I have the results listed here, which pretty much showed that they noticed an increase in certain microbes, decrease in other microbes, as well as alterations in biosynthesis and amino acid metabolism. So similar to the gut microbiome, we're also seeing a perturbed oral microbiome in AChR positive or MG patients. So in conclusion, the thought is that there is a dysbiosis, there is a change in gut microbiome listed in the top right there, and this leads to a change in the metabolites, including changes in the small chain fatty acids, which then through Treg cells may lead to the production of myasthenia gravis. So where do we go from here? What are potential therapeutic options here? So we know about probiotics. So probiotics are living microorganisms that are widely available. They have been studied in various disorders, but their role in MG needs to be further studied, but perhaps probiotics can play a role. There's also prebiotics. So these are non-digestible food ingredients that beneficially affect the host by selectively stimulating the growth and or activity of one or a limited number of bacteria in the colon. So you can imagine in the future, if we know what the problem is, there's too little Clostridium, we can use a prebiotic to perhaps increase that. And there's also the option of fecal microbiota transplantation. Also, based on what we saw in the Zhang literature, perhaps gut microbiome could serve as a biomarker for disease activity and or treatment response. So in summary, gut microbiome and MG, sort of exciting area of research, more to come. Probiotics and prebiotics are available. They're relatively safe, so perhaps can be considered. However, no specific data on MG and impact on outcome. Moving on to MG and marijuana. So marijuana has two active ingredients. We have THC, which gives the high of marijuana, which is the neuropsychotropic, and the cannabidiol. So there are FDA-approved marijuana derivatives. Epidiolex, a CBD oil, is approved for two rare forms of epilepsy, and Marinol and Sesamet has been approved for nausea and boosting appetite. However, no specific studies in MG. So marijuana is being looked at in autoimmune diseases, inflammation. There's some data for benefit in reducing spasms in MS as well as in ALS. But in summary, this is probably where we have the least data. So no studies showing benefit of marijuana for people with MG. I would say if you are using or planning to use, let your doctors know. Lastly, we'll talk about stress and myasthenia gravis. So we know that stress leads to a physiological chemical change in our body. In pregnancy, a third of patients get worse, a third stay the same, and a third get better. We know stress can impact autoimmune diseases, and many patients tell us that their MG worsens or they've had relapse in the setting of psychosocial stress. So Dova, I'll have you launch the next poll here. So true or false, I have experienced that my MG symptoms are worse during periods of increased stress. All right, we have a great response. Try to get to 60%. All right. So 81%, the vast majority of you felt that your MG got worse during periods of stress. So unfortunately, I don't have data to say that stress reduction has an impact in MG outcomes. So I think what would be interesting to see is if we took two groups of patients, one where we had interventions to reduce stress and another that just lived life normally, and see if that affected their future MG outcome. So although I don't have that data, there are two interesting studies that looked into this. Both were out of Toronto, with the senior authors being Dr. Carolina Barnett and Dr. Vera Brill. So the first study, the aim was to determine if there was an association between MG severity and levels of chronic stress, depression, and personality type. So they took 179 consecutive MG patients, and they measured their levels of disease severity using the MG impairment index level of depression, level of chronic stress, and their personality type. And what it showed was that higher MG severity showed moderate correlation with the depression score with an R of 0.52. So R is your correlation coefficient. It ranges from 0 to 1. And the closer you are to 1 means that there is a stronger association. So there was a moderate association with having high depression scores and higher MG severity. There was a lower correlation, but there was a correlation, a mild correlation with chronic stress with an R of 0.28. But only depression scores and female sex were predictive of high disease severity. The second study, their aim was to assess personality, stress, and depressive factors in MG patients that had relapse versus those that didn't have relapse. So what they did is they followed 155 patients for 6 months. They did all the assessments at baseline, and then they did the assessments at the time of their relapse, or if they never relapsed, at the 6-month mark. And what the results showed were that about 21% of these 155 patients did have a relapse during the 6-month period. And those that didn't relapse, about 12% got better and 66% were stable. So what the study showed was that at baseline, there were higher depressive scores in those patients that were going to relapse, that ended up relapsing versus non-relapsers. And higher levels of stress at baseline and a neurotic personality type predicted higher relapse rates. So the conclusion by the authors was that since emotional factors and personality type may influence MG, attention to these factors might improve care in MG patients. So what's the bottom line? The bottom line is, just like how you guys all report and what these studies show, that stress and mood disorder, including anxiety and depression, and MG are likely related. What can you do? You can assess your level of stress, some things we can control, some things we cannot, and mood disorder, and talk to your doctor for pharmacological and non-pharmacological treatment options if there are mood disorders or high levels of stress present. So in summary, although I don't have high-level data to guide some of these lifestyle interventions, I think we can all agree on some best practices. In terms of diet, this is going to impact not only your MG, but many of the other comorbidities that often come in our patients with MG. So eat a healthy diet, water, fruits, vegetable, protein, talk to a dietitian. The jury's still out on the gluten-free diet issue. Gut microbiome, exciting area, perhaps more to come, perhaps some impact on treatment options in the future. Stress, mood disorder, and MG likely related. Assess your level of stress, mood disorder, talk to your doctor. And marijuana and CBD, no studies to show benefit, but if you are using or plan to use, please talk to your doctor. I will now hand it over to Dr. Birnbaum to discuss exercise and MG. You're on mute, Dr. Birnbaum.
Okay, and I'll share my screen. Okay, and I'll just change that too. Sorry. Okay, is that okay? You can see. Can you see my slides?
We can, but it's in presenter mode.
Yeah, I need to get. How can I get that? I need to move the
You can type slideshow if you have that option.
I've managed to do before. It's just that it's kind of blocking where I need to press.
Well, this will work. This will work if you can't find it. You can go ahead with this.
Just try.
looks good.
That was okay or not?
Yep.
Okay.
Yep, looks good.
I'm in full screen mode.
Full screen mode.
Oh, okay. Okay, perfect. Okay, so hello everyone. Thank you for having me. Thank you to Dover for organizing, to Neelam for inviting me, and thank you to the MGFA organization for all your hard work and excellent work. So I'm a research physiotherapist or physical therapist at the Institute of Myology in Paris at the Pitié-Salpêtrière Hospital. So I'm going to talk to you about exercise and myasthenia gravis today. So just before we get started with the nitty-gritty of exercise and all the studies, I really wanted to make sure that we were on the same page about what exercise actually is. Because there's a lot of terms, we talk about physical activity and exercise, inactivity. So just to be clear, exercise is something that is structured, planned, repetitive, voluntary, active, and with the aim of improving your health and fitness. Whilst physical activity is the umbrella term, so exercise fits into physical activity. It's one component of physical activity, but physical activity includes any bodily movement produced by skeletal muscles, which creates energy expenditure. So often we refer to that as incidental exercise. So it can be walking upstairs, carrying your shopping, or catching the bus, anything, any type of movement.
Simone, we're only seeing your first slide. Are you advancing?
I'm not, but I feel like you don't have a full screen view. Do you?
We do. Yes,
oh,
we
I
can
see where you are. Sorry. Okay, perfect. I did advance. Thank you. Okay, I need to sorry about this. I did get it. It's because I have two screens, and it often I'm sorry, we should have checked. We made it work earlier.
We
I'm
did.
sorry, everyone.
Okay, we can see it in full screen.
Now you can see it in full screen?
Yeah, but we
Okay.
didn't see the advanced. There you go. Now
There
we
you
go.
go. Okay, so I just need to turn over on this screen. Sorry, everyone.
Okay, we're good.
So that was a lot of information without the slide support. So I won't repeat it again. But just to summarize, so physical activity is the umbrella term which encompasses any movement, whilst exercise is much more specific. And we can also talk about, when we're talking about exercise and physical activity, often we also talk about sedentary behavior, which is not the same as physical inactivity. Sedentary behavior is any time where you're sitting or lying with very low energy expenditure. However, you're awake. So it could be when you're working, reading, watching TV. So they're just kind of important concepts to keep in mind in this type of area. But we're going to focus on exercise today. So exercise training. So it's got to be specific with the aim of improving your health. So when we talk about exercise in general, there are lots of benefits that have been well researched and established in the general population and in various patient populations. Reduced mortality, which is clearly extremely important, but also exercise reduces the risk of multiple chronic diseases simultaneously, which is pretty magical. So cardiovascular disease, diabetes, many different cancers. Exercise has also been shown to be as effective as medicine for managing certain chronic diseases. Exercise has both physical and psychological benefits. So you can improve strength, aerobic capacity. You can also improve symptoms of anxiety, depression, and stress. Exercise is safe. There are no serious adverse events, as there can be with medication. Exercise can also be done throughout the lifespan, so from young kids to elderly. So how about exercise and myasthenia gravis? So in the past, as with many neurological conditions and neuromuscular diseases, exercise was considered as a trigger to worsen symptoms and exacerbate the disease in myasthenia. However, there's never been any evidence to support this dogma. So I feel like we can kind of put it in the trash for now. Maybe one day there will be something, but for now, all the evidence points to the fact that exercise is safe. However, we don't currently have any specific guidelines to help you in taking on board exercise in your life. So I've put up a few questions which I'm often asked about exercise and myasthenia. You might have other ones, so feel free to note them down and ask us at the end. So can I exercise with myasthenia? Will it cause a relapse or exacerbation? How much exercise can I do? What type of exercise is best? Will exercise improve my myasthenia? And when is it best to exercise? So to answer those questions, we're going to look at the literature that we have on exercise training in myasthenia. So before we look at those studies, we're not going to look at them in detail, but I just wanted to make it clear to you, exercise training, as opposed to medicine, is considered a very complex intervention, because exercise, when we have a pill, we can take the pill, we know the dose, we usually know what's inside the medicine and the action of the medicine. Whereas exercise is very complex with many multiple exercise and non-exercise components. How much exercise do you do? Like the duration of the session? How frequently do you do it? How often within a week? And is it regular? Is it every 3 times a week, or is it every second day? Is it once a month? That can contribute to the effects that exercise can have on you. What type of exercise? There are so many different types. So we usually talk about strength or resistance training, which is working with weights or your body weight. Aerobic or endurance exercise, so using cardiovascular fitness, working on your cardiovascular fitness. Or you can also have programs that combine both, and there can be different amounts of each in each program. Also, which body parts are involved? Your arms, your legs, your whole body. What intensity is the exercise? Is it low, moderate, high? How do you evaluate that intensity? How specific is that exercise? Is the exercise program individually tailored for you? Or is it the same program for everyone in the gym class? What about, is there any supervision? Are you doing the exercises correctly? Are they appropriate for you? Is there a coach or a therapist helping you, or are you doing it yourself? It's self-guided. Are you doing it in a group or alone? That can be important because sometimes we push ourselves more when we're with a group, or the opposite, we might push ourselves less because we don't want to look like we're not doing so well in a group. Some people, when they're alone, they'll push themselves further. It's really individual dependent. And what setting? Are you doing it at home, a hospital, a fitness club, the community? That can also influence the effects that the treatment, the exercise has on you. The other things that are important to consider in exercise training, whereas in medicine, usually we can watch to see if someone's taken the medicine. Exercise, because of all these complex and multiple components, it's not always easy to monitor or measure how much exercise has been done. And also in exercise trials, it's not always easy to know how much was done by the individuals, how long the sessions were. They could say, maybe I did it, but maybe they stopped halfway. Did they do it at the right intensity? So those are all important factors when we consider the results of exercise trials. And the other thing is exercise, as we discussed, as I mentioned earlier, it's something that's active, it's not passive. So the person is actually doing it, so they know what they're doing. So we can't have a double-blinded exercise trial, whereas with medicine, with pills, the participant doesn't need to know if it's a placebo or the active medicine. So that just means that it can be a little bit of bias in our trials. I mean, we just need to make sure we're as rigorous as possible with the rest of the methodological aspects of the trial. I just want to quickly present to you a few slides, sorry, went into French, of our recent exercise trial, just to give you an idea of what an exercise trial is. This was obviously in autoimmune myasthenia gravis. So it's the MGFA study. And we wanted to find out, as you all know, I think Neelam mentioned it, most of the literature points to the fact that there's a reduced health-related quality of life for individuals with myasthenia. So we were hoping that maybe exercise could be a treatment that could improve quality of life. So the aims of the study were to evaluate the tolerance and effectiveness of a home-based, unsupervised exercise program on quality of life in stabilized autoimmune myasthenia. So this was how the study was designed. So there was a baseline period which lasted for 3 months. That was to ensure that the participants' myasthenia was stable. Then the two groups, there was a randomization One group had usual care with no other intervention, and the other group followed the home exercise program, which lasted for 3 months. And then there was a 3-month follow-up period. So it was a multi-center trial open to male and females 18 to 70 years old. They needed to have generalized myasthenia, so the MGFA classification of 2 or 3, mild to moderate severity. The myasthenia needed to be stabilized for at least 6 months prior to being included, and they needed to live locally for practical reasons. So anyone who had pure ocular myasthenia or very severe myasthenia could not be included. Any contraindication to exercise. And we also excluded any individuals that had a very good health-related quality of life. So we evaluated that using the myasthenia quality of life score. So if the quality of life was already good, we decided not to take those people because then it would be much harder to make an improvement, and maybe it wasn't the right trial for them. So in terms of the intervention, so the duration, basically we asked the individuals, we trained them how to use their own machine and how to do the program. We asked them to exercise 3 times a week. Each session was to last 40 minutes over 12 weeks. And we showed them how to exercise at their individualized 70% of their maximal heart rate. So that was individualized. So there was a 10-minute warm-up, 20-minute endurance session, and then a 5-minute power session, and then a 5-minute cool down. The rowing machine looks like that. And we monitored the date, the duration, and the distance of their sessions, so we could get an idea of how compliant or how adherent they were to the program, which is important when we're looking at the results to know about how much they actually did, because sometimes exercise trials, they're not always successful, or we don't actually have positive results, but maybe it's because the treatment wasn't actually done as it was prescribed. So this is what it looked like. We screened 138 individuals, and we ended up randomizing 43. So 23 into the exercise group, 20 into the control group. We had 2 dropouts, both in the control group. And we analyzed, there was intention to treat analysis and case analysis. So as I said, the primary endpoint was the health-related quality of life score. We had multiple secondary outcome measures. I won't detail them all, but we looked at safety and tolerance, looking at exacerbations, medication dosages, adverse effects. We looked at myasthenia severity. We looked at immunological factors or biomarkers. We looked at psychological factors, depression, anxiety. We looked at the impact of myasthenia on your daily life using the MG-ADL score, respiratory factors, and physical factors such as upper limb and lower limb strength, fatigability, and a 6-meter walk distance. And everything in blue, they were actually evaluated blinded. So where it was possible, we tried to blind evaluators to minimize bias. So looking at the safety results, there were 2 hospitalizations. So the study lasted for 9 months. So that's quite a long period of time. And there were 2 hospitalizations for myasthenia exacerbation, but they were both in the control group. And there were several exacerbations without hospitalization, but they were also only in the control group. So looking at all the results in terms of adverse events, so serious or hospitalizations, it was just in the control group. Adverse events, there was no significant difference between the 2 groups. In terms of looking at difference in dosages or change of a medication of corticotherapy or acetylcholinesterase inhibitors, there was no significant difference between the 2 groups. So that was all positive. Looking at effectiveness, the only endpoints which did have a positive change, were in the MG-ADL score. So the individuals that did exercise, they had an improvement in their MG-ADL score at the end of the exercise period. They also had an improvement in lower limb strength, and they also had an improvement in their walking distance in the 6-minute walk test. And these improvements were not maintained at the final evaluation at the end of the study. So that kind of supports the idea that exercise was actually what changed these endpoints. Because once they stopped the exercise for the 3 months, those improvements were not maintained. So that was just one example. So you kind of saw what an exercise trial can look like. But our study was not the only study. It's the largest randomized controlled trial in myasthenia, in autoimmune myasthenia, in exercise. However, There is a lot more interest in exercise in myasthenia, and luckily we've got lots of other studies that have been done. So looking at this graph, you'll see in blue, navy blue, there have been 6 case studies on exercise. 4 of them involved athletes, like high level sport, like football players, marathon runners, ultra marathon runners. So all, individual reports of people with myasthenia participating in high level sport. And then in green or aqua green, they're interventional studies. So there's been an increase in the last couple of years of published exercise studies. In terms of what type of exercise, it's very varied. Some have done resistance, some have done aerobic, some have done mixed. The intensity is varied and the duration and the frequency is varied amongst all the studies. And all the trials have involved individuals with well-controlled myasthenia of mild to moderate severity. If you look at the numbers, I've just popped up the numbers down below of the studies. The numbers are really quite small and most of them are uncontrolled, non-randomized, no intention to treat analysis. So the largest is our study with 43. So slowly we are including more and more patients, but exercise trials are fairly difficult to run because of the practical considerations. So looking at the literature, and a lot of them have been excellent studies with lots of interesting data and interesting feasibility, looking at different options, exercise options and how feasible it is. So all of the results agree in saying that exercise in myasthenia is well tolerated, safe and feasible. Improvements have been shown in lower limb strength, walking capacity, function in daily life, balance. There's been a decrease in fatigue perception, an improvement in confidence using the exercise self-efficacy scale. We haven't managed to show an improvement in health-related quality of life. So that was our trial. We didn't manage to show it. And otherwise, it hasn't often been studied in these trials. And just to say, there's no reason why individuals with myasthenia shouldn't also reap the benefits of the general population in that exercise reduces morbidity and mortality and it increases participation and social integration. So there's specific benefits in terms of myasthenia trials, but also exercise in general does have benefits for everyone. It's just important to keep in mind the methodological limitations in some of these trials, the fact that exercise is a complex intervention, no blinding, exercise dosage might not be adequate, which means we can't always show a change. Small sample size, there are dropouts. The inclusion criteria is so limited to a specific group of individuals. So with stabilized myasthenia and mild to moderate severity mostly. And there was some shortcomings in terms of the analysis in some of these trials. But to go through some of the answers to the questions I asked in the beginning of the talk, I think that we forgot to do the poll, but that's okay. Can I exercise with MG? And the answer is definitely yes. Will it cause a relapse or exacerbation? There's no evidence to support this. There's no evidence that exercise is harmful in myasthenia, and current evidence demonstrates that exercise is safe in stable myasthenia. How much exercise can I do? There's no recipe, unfortunately. It's very much individual dependent. And I suggest that you follow the World Health Organization guidelines, which are very up to date and very useful with how much exercise in terms of the intensity and what type of exercise for adults. And also, it's really important to consider the impact that the exercise has on your daily life. So it really should be complementary, and it shouldn't be the only activity that you do in a day. You should be able to manage your daily life, work if you're working, manage the kids if you need to, or the house, or whatever you need to do in your daily life. If you do a session of exercise and then you're in bed the next day, that's not really useful to anyone. So that's really important. That's what I kind of tell most people. You really need to work out your limits. And if you can't do anything else, yeah, it's really not useful for you. It needs to be complementary. What type of exercise is best? So currently there's no evidence to prove that one type of exercise is better than another. So whether aerobic exercise is better than strength training, usually we say in the recommendations to do both because they've got different benefits. And I think in myasthenia, that's useful as well, because it's important to have the aerobic exercise for the cardiovascular benefits, but also the strength training. The strength training is important for your strength and to maintain function. As we get older, unfortunately, our strength decreases. So it's important to maintain that as best as we can. But that said, the best exercise for you is the exercise that works for you. You need to enjoy it. It needs to be accessible and feasible to you. That's the only way you're going to maintain and keep exercising in the long term. So that's really the bottom line for me in terms of what is best. Whatever you like is better than any other exercise. Whatever you will do and can do is better than anything else. So will exercise improve my myasthenia gravis? I put that question out there because there are studies in looking at exercise and the effects on the immune system. And I think that's extremely interesting and fascinating. And I think that that's an area I'd like to explore in myasthenia. We don't have any data right now on that. There were 2 studies actually. We collected some data and the Swedish group collected some data, but it's not conclusive at the moment. So exercise can improve symptoms, function, overall health, as we've seen, and also reduce anxiety and fatigue, which you've seen can contribute to worsening symptoms in myasthenia. But there isn't conclusive evidence today which looks at the effects of exercise on the immunological aspects of myasthenia. And when is it best to exercise? I'm often asked. Again, there's no specific evidence, and it's very dependent on you as a person and how you react. Some people prefer exercising in the cold weather. Some people are quite sensitive to the heat. Not everyone. Whether you do it in the morning or the afternoon or the evening, that's also up to you. Some people are much better in the morning. I know there are a lot of people with myasthenia that have difficulty in the morning. So really that's up to you. But I really suggest that you exercise when you're at your best and when it suits you, and don't set yourself up for failure. That's really important. So looking at when you're the most fatigued, your symptoms, and maybe the weather, if that's a factor that you need to take into account. So just a few take-home messages before I get onto the practicality. I've got some practical tips for you. We've made a lot of progress, and I think it's really exciting. And I really commend all the researchers out there and that are working on this area. But we do need more research. So we need some more research maybe in the type of exercise, the dosage of exercise. Are there protective effects of exercise for the disease? And what about exercise with therapy, with pharmaceutical, with medicine? How does that work? Could exercise possibly provide an enhancing effect to medicine? So then we could maybe reduce the medicine and use the exercise as an enhancer. So evidence clearly supports exercise in well-regulated myasthenia. Both aerobic and strength training are possible. Just a few practical tips, my last slide, and some advice. It needs to be progressive. You cannot go out there from doing nothing and suddenly do an hour of exercise. No one can, myasthenia or not, but really you just need to go progressively. And I also suggest once you've started exercising, maybe plateau for a little while, make sure you're okay, and then you can increase bit by bit if you like. And don't be afraid to do 5 minutes at a time. The evidence shows that the benefits of exercise can be accumulated. So you don't have to do half an hour at a time. You can do 5 minutes and you accumulate those benefits with each session. So you can do it like that. I would say more often than too much in one go. And so it's all about like a lot more often, yeah. So progressive. Feel free to discuss with a doctor or a physical therapist. We've recently done a survey, and one thing that's really come out of the survey is there's a lot of fear from people with myasthenia about exercise, and also they don't have the knowledge of what to do, and they really want to have some sort of supervision or advice. So feel free to discuss it with a doctor or physical therapist. If you're finding that someone's doesn't agree, your doctor doesn't think you should exercise, discuss that with them. If your myasthenia is stabilized, I mean, maybe get a second opinion, but otherwise, maybe there's a reason why they're not ready for you to exercise, but feel free to discuss it with them. And definitely seek advice from a physical therapist or an exercise physiologist who can inform you, educate you, set up a program, specialized, individualized program for you. That can be really useful just to get you on track, and then maybe you won't need that in the future, or maybe you can touch base with them, you know, now and then. But it doesn't mean you have to have someone all the time. But if you want someone all the time, that's okay also. Listen to yourself and monitor your symptoms. I think it's important to know that everyone can have a bad day, whether you have myasthenia or not. Some days you just, you know, a bit more tired or a bit lazier. But I think it's important to recognize also when it's beyond a bad day. And if you're, you know, often having bad days, maybe you're not as good, and maybe you need to reconsider whether you're overdoing it or not. So I said earlier to choose something you enjoy and a setting that works for you, whether it's a group, whether it's exercise alone. I think also it's really important to minimize sedentary behavior, because it's kind of a vicious cycle. If you're very sedentary, which often we can't avoid because we're working enough in our sedentary, where our work can be quite sedentary. But if you can minimize it, just getting up and down every so often, taking the stairs if it's possible, rather than the elevator, because once we get deconditioned, then it makes it even harder to get conditioned again, so to get back our fitness. So if we minimize that sedentary behavior, we kind of maintain some physical activity. That'll make it easy for us. And definitely always contact your healthcare provider if your myasthenia worsens or you have unusual fluctuations. I think I need to stop that. Yeah. Thank you, everyone, and feel free to ask any questions.
All right, we do have some questions. So I'll read them, and then, you know, it'll be obvious which one of you will answer. So I think the first one is for you, Dr. Goyal. Is the change in microbiome the cause or the effect?
Yeah, I think that's a really good question. You know, it's hard to know. I think we're still at the preliminary stages where we can just explore whether the current state of MG, how it looks different from healthy controls in the patient. You know, we would really be able to answer that question if we were somehow able to change the microbiome and see if it had an impact on MG status. So I think more to come there.
Okay, and the next question is in the same vein, sort of, couldn't the gut biome differences be more due to MG medications rather than related to the disease itself?
Yeah, I think that's a really good question. There was only one study that actually looked at the MG parameters. And so I have the table here. So this was the Zhang study, and they did have a description on the patient. So I think your question is about, could it be due to the medication? So about, you know, less than a half were on immunosuppressive agents, but they did not share what those medications are. I would say that since maybe 56% weren't on immunosuppressive agents, and this was replicated in other studies, you know, it's a little bit hard to know, but I think that's a really good question. Definitely the medications that are used to treat are going to impact the microbiome, as well as other factors as well. So that's always a question about, you know, what is causing what.
Thank you. This is for Dr. Birnbaum. If an MG patient builds muscles by weight training, does more muscles equate to less severe MG? More muscles means more neuromuscular junctions?
So if you build up more muscle, it doesn't necessarily equate to less severe myasthenia, but it does equate possibly to less symptoms, because if you're stronger, things might be easier to do. So function might be better, but it doesn't mean your myasthenia is less severe. However, if you are able to do weight training, maybe that means that your myasthenia is not so severe if you're managing to do weight training to gain muscle. Look, in terms of the junctions, sorry, the question's gone. Can you build up more junctions? So there is a feedback loop. Muscles do feed back into the neuromuscular junction. So there can be a positive effect. However, I don't have the data. I don't have the exact answer as to whether creating more junctions. I think it's more about efficiency of the neuromuscular junctions than whether you're creating more junctions. It's important to stimulate the junctions. That's a definite. And there is a feedback loop from the muscles, we call them myokines, back, which will support and stimulate the junction. But I'm not sure you can create more. I don't know if
Thank
you have
you.
anything to say.
So someone says, is asking about fatigue. She has severe fatigue and cannot imagine going to the gym. And there's another question down further in the list that is asking about yoga and Tai Chi. So I don't know if those two might be related.
In terms of fatigue, so fatigue has been extensively studied in myasthenia gravis, so perceived fatigue, like feeling much more beyond just regular tiredness. And it's definitely, it's kind of not imaginable when you're so fatigued to do anything to then go and do something even beyond what you normally need to do in your life. However, in a lot of research, even in other diseases, in other like multiple sclerosis, often doing something actually decreases that fatigue. So it's kind of about taking the first step. And I think that's where it's really important to maybe be guided and helped out by someone that really knows and can monitor fatigue, and you can work together on that. Yeah, I think that would be the best way to begin. But I think exercise can actually, it seems contradictory, but it can actually decrease fatigue, and it has been proven.
Thank you.
It was one of the myasthenia studies where it showed there was a decrease in fatigue perception.
There's a question about supplements, multivitamins, CoQ10 and others. Are there any studies on those supplements?
Currently, there are no studies on supplements. I will say that with MG as well as other neuromuscular disorders, patients do come in and talk about supplements. When there is a vitamin deficiency, we can check for it, and there we definitely recommend that you take repletion doses. But in general, I always caution about taking too many supplements. So I would say in summary, no data to say a certain supplement is going to help your MG. And if you are taking a lot of supplements, talk to your doctor and see if it's worthwhile to perhaps reduce some.
Okay. And there's a question about consumption of caffeine, green tea, and foods that are high in magnesium with regard to diet. Is that something they should be avoiding or adding to their diet?
Yeah. So high levels of magnesium do impact MG in a negative way. However, if you have normal kidney function, you're going to get rid of the metabolites and have normal electrolyte levels. So that should not be an issue. Some patients that are on pyridostigmine, even with prednisone, can have a lot of cramps, and sometimes magnesium can help with cramps. In those patients, we can use some magnesium, but cautiously.
Okay, we have a lot of questions, but I'm going to have to narrow it down since we're almost at the end of our time. How do we know when our MG is stabilized?
So I can answer from sort of a pharmacological perspective, and then Simone can talk about it because she talked about exercise when MG is stable. So MG, as you all know, is a chronic autoimmune disease. It'll have relapses and remissions. And I think when we're talking about stabilized disease is that you have some level of disease manifestation that is rather stable. So we know it's a fatigable weakness. There could be some fluctuations up and down day to day, but in general, you're at a stable dose of medications, and your doctor isn't adding or reducing your medications.
Yeah, I think there's no new symptoms suddenly that are coming it doesn't mean that you don't have symptoms, but they're kind of the same symptoms that you have come and go, and they're not worse, and they're not new symptoms. And yeah, it might be difficult for people when they're first diagnosed, but then people kind of get to know. And that's important to recognize when you're worsening. I think that's important to know when you need to contact your doctor.
Thank you. I would love to ask all these questions, but we are out of time. I appreciate your time today, Dr. Goyal and Dr. Birnbaum. It was a very interesting and exciting webinar. So we appreciate your time. We'll try to get some of those other questions answered for everyone. So have a good day, everyone, and thank you for joining us.
Thank you.
Bye-bye.
Bye-bye.